السلام عليكم ورحمة الله وبركاته. أنا دكتور أحمد السمان، أستاذ الروماتيزم في جامعة سوهاج. First of all, I would like to deeply thank Dr. Hanan Rais for this kind invitation and giving me the chance to present our article in front of the esteemed assembly. The title of our topic is about exploring the therapeutic potential of steroid and lidocaine injections in the sacroiliac joint of a naive axial spondyloarthritis patients, a comprehensive study. I have no financial disclosures or conflict of interest with the presented material in this presentation. Introduction. The sacroiliac joint plays a pivotal role in axial spondyloarthritis, and usually the disease begins from the sacroiliac and proceeds cranially. Mitigating inflammation within the joint at this early stage could potentially halt the progression of the disease. Non-steroidal anti-inflammatory drugs, anti-NF therapies, have shown efficacy in managing inflammation. The impact of steroid injection on active bone marrow edema in the sacroiliac joint remain unexplored. Most of the literature discussed its effect on pain and mobility, but none have discussed its effect on bone marrow edema and MRI signs, especially in naive axial spondyloarthritis patients. Objectives of the presented study is to investigate the effect of steroid injection on the sacroiliac joint of a naive axial spondyloarthritis patients and its effect on bone marrow edema and various disease activity outcome measures. Methods. A cohort of 136 naive axial SpA patients diagnosed according to the ASSESS criteria for axial SpA were randomly assigned into two groups. Both groups exhibited a bone marrow edema in at least one sacroiliac joint. Group 1, the active group, included 67 cases. They received triamcinolone injection in one sacroiliac joint, while Group 2, 69 cases. The control group received only subcutaneous saline injection. Both groups were monitored at baseline, before and after injection, and after 3 months. Outcome measures included ASDAS, PASFI, VAS, SPARC scores, and spine mobility assessment. Both groups underwent on and off non-steroidal treatment during the trial with no anti-NF therapies employed. All participants were 18 years old age or more. They had at least bone marrow edema of one sacroiliac joint, as that CRP score was equal to or more 1.3. They had limitation of spine mobility, either inflection, extension, or lateral bend. Exclusion criteria were completely enclosed spine, infection at the injection site or allergy to lidocaine, previous spine surgery, chronic painful condition like fibromyalgia or pregnancy that could interfere with measurements of our outcome measures. Ultrasound guided injection was done using a 7.5 to 12 megahertz probe. The probe was aligned transversely until we find the sacral hiatus, and then we go lateral upward to identify the body of the sacrum until we find the posterior superior iliac spine, and then we inject between the posterior superior iliac spine and the sacrum. We used a 22 gauge needle for injection. The injection was in plane, which means the probe parallel to the plane, and the needle was introduced from medial to lateral. Before injection, we made a confirmatory aspiration to ensure that we are not inside a vessel. In case of bilateral sacroiliac joint edema, we have chosen the joint with a higher SPARC score for injection. SPARC MRI score is a score that divides each sacroiliac joint into 4 quadrants, and each quadrant have a score. In case we are examining the bone marrow edema, we use a stair or T2 sequence, and in case we are looking for erosion or fat, we use T1 sequence. In case of bone marrow edema, we examine 6 consecutive slices, while in case of fat and erosion, we examine only 5 consecutive slices. Each quadrant have a score, and in case of bone marrow edema, if the bone marrow edema is extensive and extending more than 1 centimeter in depth, an additional score is given. Results. The mean age of the participants was around 35.7 years, with non-significant difference between the two groups. Radiographic axial SpA was present in 50 cases, 36.8%, and the remaining 86 cases 63.2% had non-radiographic axial SpA. Around 73 of cases were males. The mean disease duration was around 6.45 years. Baseline comparison between the two groups showed non-significant differences regarding VAS, ASDAS, PASFI, fingertip to floor, lateral bending, and spark scores. All these measures, except for spark erosion score, showed significant improvement after 3 months in the active group. The most evident difference was noticed in VAS, ASDAS, and spark total scores, followed by fingertip to floor, and then PASFI, and finally spark fat score. The difference between the two groups was non-significant regarding spark erosion score. This slide summarizes the outcome measures in 3 figures. Here, the first figure, we can see the difference between the active and control group in VAS score, here at baseline, and then after injection, and after 12 weeks. At baseline, there was no significant difference between the two groups, but here the blue group, which represents the active group, showed a significant difference after the injection immediately. And this difference, although it reduced, but it remains significant after 12 weeks. When we move to the second figure, we can see the ASDAS score. There is no significant difference between the two groups, but after 12 weeks, there is a significant reduction in the active group. The same thing for spark total score in the third figure. In conclusion, the combined administration of steroid and lidocaine injection demonstrated noteworthy improvement for pain, function, and spine mobility within 3 months time frame, highlighting the potential therapeutic benefits for naive axial SpA patients. Those are the references we used in the presentation. And finally, thank you for your attention.